Hi, I'm Dr. Oliver Sartor. I'm the Chief of Cancer's Disease Group, Director of Radiopharmaceutical Trials at the Mayo Clinic in Rochester, Minnesota. A pleasure for me to be here, and a pleasure to be able to present some data on new concepts of molecularly targeted radiation in prostate cancer. Now, we can think about this in a variety of ways, but the simplest way to me is to see it and treat it. And I happen to love it because I've been working at it for a long time, and it really has been rewarding to work in this field. Ideally, what you want is a target on the surface of the cancer cell, and then you design a molecule that'll bind to that target, typically a protein, then with a little linker and put a radionuclide on it. Now, some of the radionuclides, like gallium-68 and F-18, we can use to image and diagnose, and some of the other radionuclides, things like lutetium-177, actinium-225, we can use for therapy. But the nice thing is we can see it and we can treat it. And if it's not there, we probably don't want to treat it. So it is an image-based therapy that turns into the theranostic today. Now, I'm going to be talking about PSMA, but I want you to be aware that there's a lot more that we could be talking about. We talk STEAP1, STEAP2, HK2, GPC3, GRPR, TROP2, DLL3, B7H3, MUC1, maybe even FAP. It turns out there are a variety of cell surface targets that are in development. But the one that matters today is PSMA, and that's proven to be successful. Now, starting kind of back for a second, and now I'm going to refer to as molecularly targeted isotopic therapy, molecularly targeted radiation, some people call it theranostics, some people just call it radiopharmaceuticals. But the variety of targeting molecules typically been working so far with small molecules, but there are a lot more that are coming. Maybe bicycles, small little peptides, antibodies, camelid antibodies, minibodies, aptamers, lots of different ways to bind to that cell surface on the cancer cell and try to kill the tumor. There are lots of isotopes. As it turns out, these are some, but not all, of the beta emitters that have been in human studies. And beta emitters are basically like an electron, relatively small particle that comes flying out almost at the speed of light. And yes, there were approvals for strontium-89, formerly known as metastron, samarium-153, formerly known as quadramet, but lutetium-177 is the one where we are today. Half-life, about a week, 6.7 days, relatively low energy beta. Relatively low energy means it doesn't go very far, but that's okay because it goes far enough. By the way, at the bottom, I have a couple of other isotopes, copper-67, terbium-161. Keep your eye out on those as well. Now, one of the things that I really like about the isotopes is that you're going to radiate the tumor and the microenvironment. If you look on the left-hand side, you see a group of tumor cells. You see the little cartoons of the beta particles, and you see the betas flying around and hitting the tumor in something called crossfire, and you see it hitting the microenvironment. And by the way, you can overcome some heterogeneity as well, because not every cancer cell may express the target, but you could potentially kill a cell that is adjacent to the cell that you actually have the target expressed. One thing a little bit interesting about the betas is when you get down to very small groups of cells or even singular cells, you don't radiate small tumor deposit effectively. Most of the energy of the beta is just out there in space. And that, of course, means that the energy is going to be wasted. Maybe in the microenvironment it might have an effect, but you're not hitting the tumor cells to the extent you want. So crossfire is important, and a little bit of tumor bulk is important to get the best effect. Now, we have an FDA approval. Have to be the lead author of the New England Journal manuscript, published back in 2021, FDA approved in March of 2022. Overall survival improvement. Patients with metastatic CRPC, PSMA PET positive uptake greater than liver, post-ADT and ARPI, typically abiraterone and enzalutamide, and post-taxane, maybe even post-2 taxanes. So this is approved, and I'm not going to cover it because it's old hat. It's not what's new, and I'm trying to emphasize what's new. This is Pluvicto, available in your clinic today for patients with metastatic CRPC, plus an ARPI and a taxane with PSMA PET positive disease. But there's some new and important trials. PSMAfore is at the top of the list, but also SPLASH and ECLIPSE. All of these are done without a taxane pre-treatment. All of these were essentially done in taxane-naive patients, small caveats for the SPLASH and ECLIPSE, but the bottom line is that patients who progressed posted ADT and ARPI were eligible for these trials. The radiographic progression-free survival is positive, strongly positive for PSMAfore, presented originally in ESMO 2023, published in Lancet 2024, in front of the FDA right now. It's possible that this will be FDA approved in the not-too-distant future. SPLASH used a lower dose of the lutetium, probably not going to work. ECLIPSE used a PSMA INT, essentially the same dose of lutetium as a PSMAfore trial, but we haven't seen any data yet, and likely that'll be presented at ASCO. But PSMAfore is the taxane-naive important trial that could lead to an FDA approval in the near future. Now, there are also antibody trials. The TLX591 antibody is in a phase 3 trial with standard of care, plus or minus the TLX591, labeled with lutetium. And this trial is now in the safety and dosimetry lead-in phase. We haven't gotten to the randomized trial yet, but this is the phase 3 coming down the pipe. What about castrate-sensitive metastatic disease? Everything I've talked about so far is castrate-resistant metastatic disease. There's a big trial called the PSMAddition trial, 1,140 patients, completed accrual in January of 2024, a little more than a year ago. Everybody got ADT and an ARPI of choice, the randomization plus or minus PSMA-617 lutetium, and this could lead to an FDA approval if it's positive, RPFS, primary endpoint. But nevertheless, we're going to have to wait and see because we don't have any data from this trial, but it's moving up into the castrate-sensitive space. If positive, it could lead to an FDA approval, maybe 2026. We don't know. What about treating very early metastatic disease, PSMA PET positive, conventional imaging negative? Can we avoid ADT? And I raised in the session on Monday morning the idea that maybe we don't have to give ADT to these folks. Maybe we can use SBRT plus or minus lutetium. And this is the PSMAddition trial in which eligible patients will have PSMA PET positive oligometastatic disease, and they'll be randomized to radiation alone, SBRT, to the sites of metastases, plus or minus the PSMA lutetium with an MFS, metastasis-free survival endpoint. This trial is recruiting right now, open in about 60 sites globally, going to open in more sites. It's a great trial because we're going to try to avoid castration if at all possible, and a lot of men want that. Now, Synergistic opportunities for radiopharmaceuticals. I'm now going to enter into a more conjectural state. If the radionuclides, things like lutetium, damage DNA, then it's very logical that you would want to inhibit the repair of the DNA to augment the effects of the isotope. And there have been a variety of DNA repair inhibitors that are in study, but the one that's in the lead are the PARP inhibitors. And we have a study called the LuPARP study, carefully done, beautifully done. Shanine Sandhu down at Peter Mac in Melbourne, Australia, did a phase 1, escalated up to 300 milligrams BID and not giving it continuously, but day -4 to day +18, sandwiched in with lutetium, and the results look pretty good. 44% of the patients had a PSA 90. I think that looks pretty good. What about combining isotopes and immunotherapies? And there's data. This is from UCSF, in which they use pembrolizumab in combination with the PSMA lutetium. And it looks pretty good. We need more data, duration. This is published in Lancet Oncology, and it could lead to more studies that could be impactful. We don't know yet. What about alpha particles? What are alpha particles? Alpha particles are 2 protons and 2 neutrons. By the way, radium-223 is an alpha emitter. The betas, like lutetium, is 1 electron, small. It turns out that there is a huge amount of energy in an alpha, and they elicit double-strand breaks. And they don't go very far in tissue, typically only like 40 to 100 microns. So very focal radiation, very high energy radiation, and DNA damaging, leading to double-strand breaks and death. A variety of the alphas are in experimental targeted therapy, including astatine-211, lead-212, and actinium-225. Actinium-225 is in the lead. Actinium-225 has about a 10-day half-life, actually emits 4 alpha particles in its decay chain, and some of the results are interesting. Lead-212 is coming along, early results, interesting. Now, this is the one that got people motivated. This is a patient who had been through many lines of therapy, been through Lupron, docetaxel, abiraterone, enzalutamide, radium, abiraterone again, estramustine, PSA 2900, gets treated, PSMA 617 actinium, and the PSA goes all the way to undetectable. But guess what? The salivary glands are ablated too, and the guy might have a very, very, very dry mouth. Lots of studies now ongoing. Convergent, Fusion, Telix, Point, now Lilly, Bayer, Novartis, ITM, J&J, all looking at actinium. Lead-212, ArtBio, Viewpoint, Advanced Cell, Z Alpha's contemplating somatostatin. Next week, who knows? There might be something else next week. By the way, we're now incorporating SPECT, single photon emission computerized tomography, in addition to PET, to evaluate responses. And there's some interesting data emerging. Where do we go from here? PSMA lutetium is leading us forward. I think we're going to have different targets. We're going to have different isotopes. We're going to have combinations, many different combinations. We'll probably be using 2 different isotopes, isotope and immunotherapy, isotope and maybe a PARP inhibitor, maybe a radiation sensitizer, maybe even chemotherapy, probably moving it earlier in the stages. And by the way, not just prostate, it's going to move into many different cancers as well. Thank you for the opportunity to present today. My pleasure, and hope you've learned just a little bit. Thank you.